with our session. Hopefully, Dr. Mankat can join us, and also requested Caesar always from Boston Children's to join us as guest panelists. But still, in case they don't, we are on our own, and we'll try our best. So I'll ask the chat attendees also to use the chat for your comments, for your diagnosis, and any other further questions can be answered in the chat. So we'll start off with the case. I think we have a good chunk of follow-up cases with suggestive diagnosis. So I think we have 8 new cases and 3 follow-ups. We'll start off with our first case. Hopefully, Dr. Ankush is there, because I wasn't able to get through to him. Let's see. Dr. Ankush, are you there?
The history is one-liner, so we can go ahead and discuss maybe. If he wants to be there, we can come back to this.
Sure. Okay. No, because the history is one-liner, I wanted him to be there. All right.
Yeah.
We'll move on to our second case. Yeah. Okay, Debang, now over to you.
Okay, this is a 1-year-old male child, sir, who had come to us at 4 months of age. Initially, he had an ICU history. It was a normal delivery, LSCS 3.2 kgs, but had neonatal hypoglycemic brain injury and had hypoglycemia as well, for which the child was admitted to an ICU. Then he was developing normally at 3.5 months of age. He had lower respiratory tract infection, for which he was admitted to hospital. In the hospital, he had 1 episode of GTCS, discharged after 7 days, and parents noticed that he had abnormal movements following the discharge, dystonic posturing, and he had lost a milestone, which he had achieved partial neck control. He had lost a milestone, and there was dystonic posturing. So when he came to us, we did an MRI.
All right. MRI at what age? At 4.5 months?
4 months of age.
Yeah, okay. All right. I have only external images and slightly pixelated over here, but selected T2 axial on top, and we can appreciate that there is some degree of cortical atrophy, especially in the frontal lobe, so they're on both sides. The main changes are in the deep brain nuclei, the basal ganglia. And you can appreciate that there is the bilateral hyperintensities, at least on the T2 sequences, more confluent over there. Relative the sparing of the thalami and also the internal capsules. Coming down lower, cannot appreciate any other abnormalities given the quality of the images. Maybe some hyperintensity in the middle cerebral peduncles, but again, cannot be sure because I think there's a movement artifact also over there. This is the flare. On the flare, you can appreciate that the hyperintense changes now demonstrate cavitatory appearance. T1s also have similar hypointense changes, and nothing on the diffusion. So there is the bilateral gliosis or encephalomalacia kind of changes with it. The reduced volume of the deep brain nuclei. You can appreciate that the frontal horns are dilated because of the underlying reduction in the caudate nucleus volume. Corpus callosum is slightly thinned, especially in the segments of the body. Other than that, I think midbrain, the vermis and the brain spawns demonstrated normal appearance. So overall changes of basal ganglia, necrosis, cavitations with some degree of frontal lobe atrophy. On this imaging, these changes are in the chronic stage, so the specificity kind of reduces on imaging at least. But again, here a wide list of differentials. I do not have a GRE sequence to see if there's calcification, but does not look like a mineralizing angiopathy. They're usually slightly asymmetrical. So we're looking at mitochondrial disorders, thiamine-related disorders, and post-infective sequelae as the possibilities. In the interferonopathies, the ADAR1 mutation is known to have bilateral basal ganglia cavitation. So these are the main differentials on the imaging given the chronic nature of the imaging findings. So yeah, I'll open the case if anyone else has further comments or anything to add to it.
So lots of these children with striatal necrosis, you hardly hit a diagnosis genetically as well. Not sure where metabolic and genetic, most of them turn out to be negative. and they don't have another episode most of the times. So, not if it is a genetic or metabolic, whether it's a progressive thing, further episodes, those things have not happened in many of these children. Very occasionally we get a diagnosis of some mitochondrial, but most are negative. That's why I think that they just leave it as striatal necrosis, simple striatal necrosis.
So the commonest cause of bilateral striatal necrosis would still be viral encephalitis, looking at the worldwide picture, I think. And then you're left with those mitochondrial entities, including things like ADAR1 and all that. But we haven't seen so much necrosis with ADAR1, to be honest. But those would be the differentials.
So symmetric case in the acquired pathologies?
Symmetric, it can be with ADAR1. And yes, symmetric, it can be with viral encephalitis as well.
Okay. Any particular viruses that you people have been able to nail it down to so that we can look at them?
Apart from the usuals, frankly, we have had a couple which turn out to be astroviruses, but they were only picked up on metagenomics, Lokesh. It's just like not even picked up normally in serology.
Yeah. Okay. So how much?
Same time, if you have samples, I can line you up with the metagenomics lab that they can.
Okay.
But it's a long shot.
Yeah, for future collaboration, maybe useful. Yeah. Definitely. Thanks, Kish.
All right. So I think we have Dr. Ankush as panelist. So Dr. Ankush, if you are there, over to you.
Yes. Actually, can you hear me?
Yeah, please go.
So I mean, this is otherwise a developmentally normal 15-year-old boy. He had some headaches, and there was some history of abnormal seizure, one episode of seizure, and he had abnormal behavior. Okay, so at that point of time, an MRI, because he had a seizure, an MRI brain was done, and that MRI showed multifocal lesions, which was diagnosed as, the child was diagnosed as Adam, and was treated with pulse methylprednisone with oral steroid taper. With pulse methylprednisone, he improved initially, but with oral steroid taper, he again, that behavior deteriorated again. So a repeat MRI brain was done. Now this repeat MRI showed, the lesions had deteriorated. Clinically there were, when the child presented to me, the child only had abnormal behavior. Otherwise, he came walking into my OPD. So, but radiologically, the lesions had deteriorated. So, if you want, you can show the MRI.
No encephalopathy, no, Dr. Ankush?
No. He came to me in the OPD walking.
Yeah. So, all right. So I have the latest MR images, and as you have described, multifocal lesions involving the gray and white matter structures. They also demonstrate restricted diffusion over there, especially along the peripheral aspects. These are the FLAIR images, and you can appreciate again multifocal appearance, bilateral hemispheres, peripheral regions also involving some degree of the deep gray nuclei over there. Predominantly supratentorial, could not appreciate any abnormalities in the brainstem or the cerebellum. On the SWI sequence, on the gradient sequences, we had these areas of hemorrhagic foci within the abnormal lesions. As you can see over there, again, widespread in almost all the lesions. You have these multiple punctate foci of blooming on the SWI sequences. T2s again, just to demonstrate the multifocal appearance. Peripherally, it demonstrates these edematous changes with some central, again, central hyperintensities with some peripheral isointensities over there. The spinal cord, I had only the cervical cord. It did not demonstrate any focal lesions over there. Post contrast, you had this predominantly peripheral enhancement. Some were complete, some demonstrated some incomplete peripheral enhancement. So multifocal lesions with peripheral to incomplete peripheral enhancement, hemorrhagic foci within the lesions. The optic nerves, I could appreciate that there was at least the proximal segments of the intracranial segments demonstrated some degree of enhancement. There was no paranasal sinus diseases or significant paranasal sinus disease or inflammation over there. So based on that, I saw your note of ADEM, hemorrhagic ADEM. I have not come across an ADEM with such hemorrhagic components. Though the multifocal lesions look like ADEM, I could find few case reports with MOG related changes which have these hemorrhagic components within it. They are fulminant cases, but this child did not have encephalopathy, so I'm not sure if ADEM is to be used as a diagnosis. I wasn't aware of the immunocompromised or immune status of the child. So infections also could present. Fungal infections, especially the hemorrhagic components, is what I thought of. Then toxoplasmosis and sepsis, additional sepsis can also have these hemorrhagic changes. So these were the differentials which are okay. Sorry, go ahead.
So I mean, we did a lumbar puncture, and
Yeah.
we did antibodies and staining for fungal stains also. Histoplasmosis. I involved the infectious disease specialist also. So toxoplasmosis, all the Indian ink preparation, everything was negative. And otherwise also, I mean, the PCR testing for routine, bacteria, viruses, everything was negative. Child was immunocompetent, HIV negative.
No hemiparesis or anything like that? I mean,
no. He came walking into my room.
All right.
And he used to walk around in the ICU also. But he was, yes, there was some, abnormal behavior. I mean, he kept saying that he wants to go home. I mean, that behavior was abnormal. And so ultimately, after giving, we did a plasmapheresis also. We repeated methyl prednisone pulse, and we gave IVIG also. But so the repeat MRI, repeat MRI was similar. I mean, there was hardly any changes.
I couldn't find an angio or a vessel wall to just check for any inflammatory changes in the vessels.
Okay, and angio was not done.
Okay. Okay. So vasculitis markers, anything to stand out?
I think Dr. Vijay has asked whether it could be primary CNS vasculitis.
Okay. NMO NMO and MOG were done. They were negative.
Did we attempt a biopsy of the lesion? Ankush, did you attempt a biopsy of the lesion?
Child actually, sir, we were planning to do a biopsy, but the child actually, that is what my question is. But the child was very well. He was walking in the room. So, biopsy isn't planned, but I'm not sure. Is it very? Should we do a biopsy now?
If the lesions are if the lesions are persistent, there is a.
Hello. Hello.
Sir, yeah, Dr. Ankush, we can hear you.
You are audible. You are audible.
Sir, we actually we couldn't come to a consensus. Somebody wanted a biopsy. Others, biopsy. Ideally, biopsy is required, but we were not very sure. Lest the child deteriorate after biopsy. We were thinking about any complications after brain biopsy. So that is why we haven't yet done a biopsy.
Only thing which will worsen after biopsy is if there's an aspergillus infection. Sometimes it can worsen post surgery because there is hemorrhagic component to it, multiple places, and fungal kind of differential is strong. So some of these lesions are quite superficial. So you'll have to look at a angio-invasive process, either vasculitic or fungal. Those are the two prominent differentials here.
So we have done a plasmapheresis. We have given IVIG, two doses of pulse methyl prednisone, and yes, that is what we have done. So, should I continue immunomodulation with rituximab, or this is not hemorrhagic ADEM. No? This is not that is ruled out. No? Hemorrhagic ADEM.
There's no encephalopathy itself, so ADEM. I don't know.
ADEM actually ADEM is a clinical diagnosis, so this is not ADEM. First episode of acute.
No, I got it, but it's not typical for an ADEM. I haven't seen such hemorrhagic components in ADEM.
So that is why I mean, there were two radiologists in our hospital. One said this is fungal, the other one said this is Adam. So I mean, I don't know.
I think
So,
as Dr.
I mean-
Lokesh and Dr. Vijay has mentioned also, vasculitis, fungal are the two primary considerations.
So, Lokesh, sir, should I
Yeah.
now go for biopsy or should
I
I
would-
continue with immunomodulation?
No, I would get a diagnosis here, Ankush. Explaining that this.
You are
We should
suggesting
get-
biopsy, huh?
I think so. You can do a beta galactomannan in the blood to start off. Okay.
So that is negative. That is negative.
Negative.
ID
Okay,
specialist
yeah.
was involved from the very beginning.
Okay, yeah, that's fine then. That's fine. So we have had children like this where only the biopsy was the only thing which gave us the answer. Biopsy, along with that, you need to do PCR on the biopsy sample.
So what was the CSF protein?
Everything was normal.
Normal means CSF
Cells,
protein.
protein, everything was.
Maybe just
I'll have to
it's
get
normal. It's just
well, between 25 to 45. It was
right,
less than 45.
right. Lokesh, as you mentioned, angio-invasive, a few aspergillus have said this is too diffuse to be a single fungal process, which is, angio-invasive. You see lesions more very, asymmetric rather than, this is asymmetric, but not asymmetric as you see in a fungal infection. I had two similar cases where we just held on with our second step of immunomodulation, and few months later we did the MRI. Child was better. I was just wondering, we went up so fast with so much. What was our criteria of just going bang, 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 two pulses of methylpred, IVIG, plasmapheresis, and child is roaming around in PICU. So we were just nervous by the MRI images.
But
that's what we were doing.
I mean,
We are losing you. We are losing your voice.
First MRI did not have hemorrhagic component. The first MRI did not have hemorrhagic component.
Right.
So after pulsing, the repeat MRI showed these hemorrhages. But that is why
Right.
then we panicked. I mean, then so one of my radiologists in my hospital, he was very sure this is hemorrhagic, Adam. So I gave we gave IVIG also. We did a plasmapheresis also.
Like I would have because plasmapheresis is great. So methylpred, plasmapheresis, oral steroids, send the child home, remove him from your vision, so that you don't panic every day when you see him on the rounds with the MRI, and like call him back in few weeks' time. That's the answer. Because
so, I mean, would you go for a biopsy right now or
definitely not. Definitely not.
Okay.
Because I think this child is not worse. I would just follow him up, send him home on oral steroids.
Yes, right now he's on oral steroids.
You can give them the option, but I'm sure parents will say no to it. So medico-legally, you can just be safe.
Okay. Because fungal,
Yeah.
I mean, the child is immunocompetent. So everybody was wondering that, I mean...
No, immunocompetent children can have it. That's not, and aspergillus is the one, angio-invasive. But if galactomannan is a good marker.
That is negative. That is negative.
But CSF, beta-D glucan must be negative, I'm sure. So then
yes.
it's sort of, and it is more symmetrical than one sees with the angio-invasive aspergillus. And yeah, so that's what I feel. And HLH is something, it was mentioned. So I'm not sure if the contrast images were helpful for that, Nihaal.
I think Vijay once again has mentioned primary CNS angiitis. Kish, you have any difference of opinion?
No, I don't actually. I was thinking about Bijoy's messages as well, and I've got Sneha with me here as well, by the way, at the moment. And we were thinking, ADEM typically, the lesions without the hemorrhagic element, they look like ADEM, but ADEM and hemorrhage don't really sync together. So we were also thinking on the ground, on the lines of what, Bijoy and even Ramandeep have been talking about. So things like HLH, things like vasculitis, and fungal always should be considered when we have such hemorrhagic lesions. One question on the blood film, you don't have any other evidence of lymphoma, leukemia, and that kind of spectrum, right?
No. CBC was absolutely no. CBC it was absolutely no.
It's just on the basis of having its exactly similar MRI in two patients, and they are just normal now. Those patients, we panicked as well, and we gave methalpid, and we didn't have plasma. We did give IVIG and sent them home. Came back in 3 months, and the MRI was so much better.
Okay, so you're telling me to wait. Huh?
Like, but there are more experienced people who are probably mentioning that one has to, but that's just my personal opinion, right? CNS HLH is the only thing, if it's a possible, Nihaal, if radiologically, or if that could be, that's the only sort of possibility which could be considered. Did you send CSF oligoclonal bands?
Yes, that was also negative.
Okay.
NMO, MOG, CSF oligoclonal bands, it was all negative.
Yeah, the only thing with HLH, I'm not sure if that's typical. I mean, they usually don't have these multifocal appearances, and cerebellar more commonly it's involved. I haven't seen multifocal areas of abnormalities in HLH, but Dr. Mankar has published recently in AJNR, so he would have a better experience of HLH. Yeah, so I think we're going with Dr. Vijay and Dr. what Mankar said.
See, vasculitis is definitely there. Like, that is just a term. Because vasculitis is hemorrhage plus. But the question is this a one-time vasculitis following a viral infection or some form of a trigger which will just go away in few months, or is ongoing CNS vasculitis? That's the issue. Because vasculitis term as such is, doesn't help. Because this is vasculitis, hemorrhage with demyelination. But maybe one time. So TB also has vasculitis, TB vasculitis. So this is some sort of a vasculitis, but maybe this vasculitis process is one-off process which will now go away with the process. Primary CNS angiitis, I'm not sure if CSF pressure was done, but CSF pressure can be high. Proteins are high, cells are slightly higher. Primary CNS angiitis, not always, but mostly.
No. CSF pressure was normal, and counts and protein were also normal.
So primary CNS angiitis gives you that clue. Short of biopsy.
Are there any things systemically, like in the spleen and other hematogenous?
No.
But they have had an ultrasound and things like.
Ultrasound, clinically there was no organomegaly.
Sorry?
Clinically, there was no organomegaly.
Clinically, okay, but have you actually screened them for like blood pressure, renal arteries, kidneys, spleen?
In routine testing was done. CBC, LFT, RFT, everything was normal.
I'm just thinking about things that are hemorrhagic and give so much edema around them. You get your infarcts, your septic emboli, your fungal diseases.
But the first MRI had no hemorrhagic component.
Okay.
The one thing I missed mentioning was GFAP. Do GFAP antibodies. Again, it's a great mimicker. You have so many lesions, and the child is well. You can do it in Kochi.
Yeah.
Even though it's not classical, but GFAP we should rule out.
Okay. Can you, which lab exactly does it?
Amrita Institute, Kochi.
Okay, Amrita.
So I'm not saying that this is exactly like GFAP, but for GFAP, we are still learning. We have accumulated cases because European consortium is accumulating. So it has such varied presentation, because the classical one, as mentioned, is perimedullary enhancement, but there are patients who have got significant demyelination, looking well child, good prognosis, respond to steroid. So MRI is disproportionate to the child's clinical profile, and MOG NMO negative, GFAP gives the answers. So there's no harm in doing it.
I didn't know which lab does it. Maybe I'll
And no
try to
harm in
contact.
doing it, but we don't think this looks like GFAP, at least on the few cases that we all have seen. But yeah, I guess no harm in doing it.
No harm in doing, yeah. Because we are still learning about it.
All right then. Thanks everyone. We'll move on to our next case. I think.
Thank you.
Slightly running short of time. Thanks, Ankush. All right, Prituja, over to you. You're there.
Yes, sir.
Yes.
Good evening, everyone. We have a 5.5 years old female child with normal birth history, normal development, and no significant past history, presenting with history of one episode of projectile vomiting, followed by convergence of eyeballs since last 15 days prior to presentation to us. And there was, on examination, restriction of the lateral gaze and was fundus examination. Bilateral papillary edema was noted. We did an MRI brain for this child.
All right. So non-contrast flare sequences over there. And you can appreciate that there is incomplete or non-suppression of the sulcal spaces, especially in the parietal regions, the bilateral posterior frontal regions. Also extending down up to the occipital and temporal lobes. So there is some degree of ventriculomegaly with some periventricular edematous changes. More inferiorly, you have, again, the sulcal spaces are not completely suppressed. There is some flare signal changes in the interfolial spaces on both sides. You can appreciate also the, at least along the trigeminal nerves, or it is slightly blurred out or it's not very clear. And there are some prominent cystic spaces or possibly perivascular spaces in the bilateral cerebral hemispheres on both sides over there. Nothing on the diffusion, at least in the parenchyma. I found this focal abnormality in the lateral wall of the right cavernous sinus. And again, on the T2 sequences, you have the cerebellar hyperintensities, the predominant cystic changes, and the Fiesta sequence picked up a focal lesion over there in the intraconnector segment on the right side. Post-contrast, contrast dose was slightly higher than for the child's weight, so it's slightly attenuated contrast abnormalities, especially along the parietal lobe and on the occipital lobes. Could not appreciate any basal enhancement, external enhancement. Again, the canalicular segment enhances over there. No focal lesions in the parenchyma. And just to reiterate the changes of intracranial hypertension, you have the papillary edematous changes, prominent perioptic sheaths, the lateral sinuses the transverse sinuses were stenosed, and there was a partial empty cella. So changes of intracranial hypertension. Then we thought of possibility of an infective etiology, but there was no focal parenchymal lesions, given that the cerebellar changes at least demonstrated the cystic foci, subpile abnormalities. A possibility of a diffuse tumor or leptomeningeal tumor was raised, possibly in the early stage. The one which stood out was the diffuse leptomeningeal granuloma tumor. Sarcoidosis, TB were considered. I think CSF was done, and we ruled that out. So, Prituja, do you have a follow-up? Fine wasn't screened for this child. Yeah, Prituja?
We had done a CSF analysis, and CSF opening pressure was more than 200 with no cells, protein of 10 and sugar of 51. We sent CSF for malignant cells, and that has come out to be positive. We had given a dose of mannitol to the child and have sent on acetazolamide. So we've called the parents for follow-up, but they haven't reached out to us yet, sir.
All right. So any further comments or anything to add?
We couldn't actually type the cells. All they could say, tell us it is definitely malignant cells, not normal. But they to do further any this one, obviously we don't have anything to biopsy. So at this point, it is challenging to see what else to be done.
Maybe if it was fine. Yeah, sorry.
Now, did you have post-contrast images to show us on this one?
Yeah.
What made you think about DLGNT and all?
The cystic space in the cerebellum, no parenchymal abnormalities. Yeah, that was the main changes, and the nodular lesions in the at least in the 7th and 8th nerve over there on the right side. So that is what I thought. Maybe it's an early finding of a DLGNT before it's completely blown out.
It is interesting, I think, these observations. The problem I have with the terminology in pathology, DLGNT is not exactly a malignant neoplasm. So you might want to ask the pathologist why they call it malignant.
In a sense, the DGLNT malignant in the sense that some of them can have a high MIB index and they rapidly progress, isn't it? Kesh, we lost actually two
There
children.
are two types. In fact, none of the labs I'm aware of, even here, I subtype the DLGNT into type 1 and type 2. There are two types. But I don't know whether any of the two types are frankly malignant because they, by definition, they are glioneuronal tumors, which are on the benign end of the spectrum.
Actually, we lost two children to this tumor. Their MIB index were around 20, 24. And in spite of, they had a very indolent course for initial 1 year and then progressed slowly, both the spinal cord and brain. And we lost both of them. So that is why, but these malignant cells, as I said, they couldn't type it. They said they are abnormal cells, not normal looking cells.
Yeah.
But that's what they could say on the CSF.
I would agree with DLGNT on radiological criteria. You can see that there is folial infiltration as well in the cerebellum out there on the picture shown. So, but I just wanted to question the pathologist about the term malignant and whether they could characterize it any further.
Abnormal, yeah, probably abnormal cells.
It's also strange that you lost two children. If it's to do with a primary tumor per se, I think that's an important message to put across because generally they're quite indolent.
No, this is for the progressive tumor progression where they had Kish, both of them. One child presented with a bleed initially, and then repeat scan showed there was a tumor and then metastasis within 6 weeks, and then he progressed. Other child took almost 3 years before he progressed and died.
Okay.
Yeah.
Dr. Lokesh, I think many have mentioned.
If you all have the histology slides and you can send it to us digitally, we can get a second opinion on them.
Yeah, sure. I'll ask the pathology team. Bijay, the blood films are blood counts are not showing any abnormality.
Just about, do we need to screen the spine, Dr. Lokesh, Dr. Mankad, just to see if there might be a more prominent lesion over there?
If they come back, we'll do it.
Yeah. Right. Sure.
Yeah. Thank you.
Thank you.
Thank you. All right. To our next case, Anas.
So this is a 16-month-old male child born to non-consanguineous marriage, developing normal premorbidly. Presented to us, the child woke up with excessive crying and irritability after waking up from sleep, and later the parents realized positive movements on right side and upper and lower limbs. He had history of chicken pox at 9 months of age. On examination, he was awake, alert, crying but consolable. There's deviation of angle of mouth to left side. Power was 2/5 in both upper and lower limbs. Flaccidity was present. He later on day 3 of admission, he developed hemidystonia on the right side of face and upper limb, multiple episodes which responded to clonazepam. Because in view of history of chickenpox, we have done CSF. CSF was normal, no cells. CSF and serum paired varicella antibodies present, which is IgG positive. CSF varicella DNA PCR also done, which was negative.
Okay. So MRI at 16 months of age. Was it done after the MRI, Anas? Before the MRI?
The MRI, yeah, sir, after the MRI. These are all on the day of the admission. We have taken samples and done MRI.
Okay. All right. So MRI have diffusion changes, and you can appreciate there is a predominant left middle cerebral artery infarct. Yeah, so that was the only finding I could appreciate on the diffusion changes. Then we did a vessel wall imaging and a angiography, And on the vessel wall, we can appreciate that there is abnormal enhancement of the left middle cerebral artery. Also, the cortical branches demonstrate some degree of enhancement over there in comparison to the contralateral side. So looking at possible vasculitis changes. On the MR angiography source images, again, we have some abnormality, irregularity of the peripheral regions of the middle cerebral artery over there, and paucity of the left terminal branches of the middle cerebral artery. So yeah, we came up with the diagnosis of varicella zoster related vasculopathy due to the inflammatory changes on the wall. I just looked at a few papers between the timeline of the onset of the varicella and the presentation of stroke. The most common findings what they found was in around 60 patients was around 1 to 2 months going down. Around 6 months was the least frequent changes. And the only abnormality they found was related to monophasic arteriopathy was the history of varicella. They proposed that the possibility of the route of transmission was from the trigeminal ganglion. Again, the most common time period was 1 to 3 months, which resulted in stroke of at least of these arterial systems. And again, another paper demonstrating 60 patients, 22 had varicella, and 0 to 2 months and 2 to 4 months were the more common period timelines for the presentation of stroke. Basal ganglia infarcts and anterior and large circulation infarcts were more common in the varicella-related patients. So, Anas, if you want to just go through the algorithm, yeah.
Yeah, so this is the algorithm we follow for suspected varicella vasculopathy. We're doing CSF and PCR to check for DNA, as well as antibodies paired with serum and CSF antibodies for varicella. And then the main query we had, we wanted to know what the other institutes are following, what protocol are they following for the treatment, because we had a debate regarding to give steroids or not. We started with IV acyclovir as well as IV methylprednisolone, but how long to continue either of those, and does it merit a long treatment was the main query we had.
Kesh, what does UK do currently? Any idea?
So I wanted to know, you've suspected the vis-a-vis vasculopathy. Is that kind of confirmed or not?
As per the laboratory and history-wise and clinically, it is. I mean, unless there are other alternatives, but from other workup of stroke has been negative so far.
Okay.
Oh, antibodies were positive in the CSF.
Yes. So, I mean, I can find more details for you, but there's not much more actively that is being done apart from making sure that they don't have future strokes, which is neuroprotection with aspirin. And then the whole idea is to follow these patients closely. In terms of surveillance imaging, at the moment, we do 6 months and then 1 year follow-ups. But the fact is that the arteriopathy per se, if you can go back to the scan showing the arteriopathy, could you confirm that? I mean, there is a bit of fuzziness around the vessel walls. But did you do an MRA or something?
Yeah, the lower one is MRA.
Yeah. They do tend to follow a rule of thirds, right? A third of them stay as they are, a third of them improve, and a third get better with time. Steroids are not used here on a regular basis, I must say that. But I think if you were to look at the American data, they are tending to use FCAI steroids quite frequently from the Stanford data.
Okay.
See,
Yeah,
I'm not so sure whether IV acyclovir will be useful, because there is a long latency period between the chickenpox and the stroke, and this is a big undertaking to give for a child. So I remember we used to, like Dr. Mankad said, we used to give aspirin and possibly not more than that. At least got an answer, but not more than that, really.
Yeah, that's a debate, Dr. Rashmi. We actually don't have consensus. So I tried to get in touch with the Canadian team. I couldn't get a response so far what they do. But this is the protocol which has been published. Tentative protocol.
This protocol is from the Canadian team, is it?
Yeah, I think so. This
Anas?
is okay.
Anas, can you confirm? Okay.
Probably we'll get some more
All right,
answers.
yeah.
We'll speak to that. Thank you.
Okay. All right. The case by sorry, that's from Dr. Ramesh and Apurva, if you're there. I don't see them, but okay, I'll go ahead with the case. So this was a 3-year-old with developmental delay. A male child with developmental delay had the sparse hyperpigmented hair, hypertelorism, a broad nose over there, had sparse eyebrows with spasticity, microcephaly, and acute left upper motor neuron hemiparesis. Based on the clinical profile, before the MRI was done, they were suspecting an inborn error metabolism, something like homocystinuria, kind of a spectrum disorder. Anything to add, Dr. Lokesh, on the images, the clinical pictures? Any alopecia there? I couldn't appreciate on the images.
Nothing else.
Okay, all right. So then we got an MRI suspecting an inborn error metabolism, and turned out to be we had a structural abnormality. T2 axial sequences, supratentorial brain did not demonstrate any any malformations or any signal changes. But the main changes were in the infratentorial regions. We had this fusion of the cerebellar hemispheres, more along the inferior and middle cerebral hemispheres. We had this Robbins synapses kind of a picture. Also with inferior tonsillar ectopia on both sides, giving a TRE1 deformity or malformation. The corpus callosum is slightly thinned out. If you observe on the T1 weighted zoomed in images of the skeletal sequences, for a 3-year-old, the anterior pituitary gland was hyperplastic. There was an ectopic pituitary sequence in the infundibulous stalk, and also the olfactory system was slightly hyperplastic for given the age of the child. So we're looking at Roman synapses with some additional changes in the pituitary gland and also in the olfactory system. The only thing we couldn't tie down is if there is an association between the endocrinal abnormalities or the pituitary abnormalities and the Roman synapses. The only syndromic changes which we thought of was Gomez-Lopez-Hernandez syndrome, but this child did not have alopecia, no trigeminal anesthesia, and it's also not known to be associated with any pituitary abnormalities or any olfactory system abnormalities. So the question was if there's any similar experience with these additional changes to the infratentorial abnormalities, and also the clinical presentation if it points towards something.
Nihaal, how would you summarize this?
I couldn't put it together, but Roman synapses in general is sporadic, so it's unlikely to get a diagnosis.
So the only syndrome that is associated with Gomez Hernandez. But we have seen this now with tubulopathies as well. Mm-hmm. Now, GLH doesn't have a known genetic basis as much as I remember, right?
Yeah.
Yeah. So in the context of other genes, are these patients being worked up comprehensively for a genetic screen?
I'm not sure. I think Dr. Ramesh would have given better.
Because here you have a pituitary dysfunction as well, isn't it?
Yeah.
So you've got Roman synapses, pituitary dysfunction, and are you trying to show something in the optic nerves and olfactories, or is that
the olfactories are slightly reduced for the 3-year-old, but
left particularly, isn't it?
Yeah,
so midline effects, and then you have corpus callosum that looks a bit dysmorphic as well.
Yeah, and then yeah. I don't think we have the treating
acute hemiplegia, but did you pick up anything on the diffusion?
No, nothing on diffusion.
And then you have the tonsillar ectopia as well on top of that, isn't it?
Yeah.
I think you have to shoot this with a genetic bazooka.
All right. If we get something, I'll get back to you. Okay, to our next case, Dr. Vivek.
Yeah. So this is a 10-year-old girl who I had seen just a week back, and she had complained only for the last 3 months of progressive right vision loss. And at the time, the ophthalmologist felt that in the right eye as well as in the left, there was evidence of mild optic disc swelling. So they thought that she had optic neuritis. But that's the picture which she had recently on the optic disc examination, which we just had now. But at that time, if you see, there's disc margin blurring, and that lesion which is seen on the left side has not been mentioned from 3 months back. This is just a latest fundi which my pediatric ophthalmic colleague took recently. So that one I don't have. I think she is going to be online. She will be in the meeting as well, Deepa. So I might, if she comes, I'll ask her if she can tell us the ophthalmology finding from more recent time. So at the time when it was thought that this is optic neuritis, she got admitted in a hospital. She was given methylprednisolone, as we all do. Her color vision was intact. This had been going on for 3 months prior to this, prior to coming to medical attention. But anyhow, she was given 5 days of methylpred, but that didn't help her. And she also had MOG and NMO scent, which were negative. And then things were just chugging along, and this had been 1.5 months back. This all was done, and they came to me because now the ophthalmologist, when they checked, she also had left eye. This is from the left eye, so the left eye was getting involved with a scar present on the superior side, and this more like a morning glory appearance. So, and CSF was normal in that admission. And they did a MRI which was 6 mm cuts. In that admission around 6-7 weeks back, when the MPS was given, CSF was done, and that was reported as normal. Now when she came to me this time, she had a poor response to steroid. Child had involvement of the left eye as well, and she hadn't had any autoimmune markers being positive. Father told me there was a small lesion on the skull from birth, and I didn't give much notice to it. Only after the MRI, I realized that it was so important. And I just thought that was some sort of a boil he was mentioning, or I didn't even examine it. So second time when they came to me just 7 days back, we did a detailed MRI with contrast, with orbital cuts, which Nihaal is going to show, right? And then we can discuss.
All right, Dr. Yeah, so these are the orbital cuts, T2 sequences, the first two images over there. And you can appreciate optic nerve abnormality, especially on the right side. Around the periphery, you have these T2 hypointense changes. The sheet is thickened over there. And if you also observe on the left side, at least the lateral aspect of the sheet over there is also demonstrating T2 hypointense changes. T1 again is demonstrate iso-intensity, is more on the right side. The C sequence better demonstrates the abnormality of the right optic nerve, but if you also see on the left optic nerve, this is the normal CSF space along the anterior aspect, whereas the posterior aspect demonstrates T2 hypointense changes. Post-contrast study, intense enhancement of the right-sided lesion, and there was some degree of peripheral enhancement of the left optic nerve. If you see on the coronal sequences again, the right optic lesion is very well demonstrated. There is some degree of blurring and some degree of enhancement of the left optic nerve lesion. Then the brain, again, selected images of the abnormalities. The bilateral trigeminals had these focal areas of intensely enhancing lesions. The bilateral canalicular segments of the 7th and 8th nerves demonstrated these intensely enhancing lesions over there. The scalp also had this focal lesion over there. And if you see on the right, I thought there was some asymmetry in the ears with the external auditory canals. You can see that the right ear is slightly more intensely enhancing, slightly more thickened over there. Again, over here, you see the image on the right side on the bottom. Again, you have some areas of abnormal enhancement and slightly asymmetry in the ears on both sides. There was some focal areas of specific spaces in the right subcortical frontal regions. So the spectrum of abnormalities, we're thinking of NF2 with optic sheath meningiomas, right side and possibly also on the left side with these intracranial schwannomas or neuromas in the trigeminal nerve, the seventh nerve, and also the subcutaneous or scalp plexiform neuromas, and also the right ear abnormalities. So the constellation of findings, we're thinking of NF2. So if any further comments, Dr. Vivek, anything particular to be checked in this child?
So spine screen is normal still, so it doesn't show any tumor.
All right, yeah, we just wanted to illustrate the multiple findings of NF2 given the orbital abnormalities and also the various cranial nerve abnormalities. So, yeah. Is that it, Dr. Vivek?
Yeah, and I'm not sure if my ophthal colleague is here, so she can tell about the. Is Deepa, are you there? Do I have two links
no, I can't.
active? Two links active? No.
No, I can't find Deepa.
Okay, because the eye findings were really interesting, so suggestive of NF, because it can look like the edema is more because of a scar, which prevents the optic nerve drainage of exoplasm, causing a edema in the superior quadrant. So this scar, and that's why maybe misdiagnosed as optic neuritis. And the value of doing a proper MRI, when we looked at the 6 mm cut MRI, you cannot properly see the lesions, while you can see them now much better. There must have been some progression also, but at least the small ones. Somebody asked about the management. Unfortunately, because there are multiple lesions, one can remove the meningioma, but rest all one cannot deal with. One can do, gamma knife surgery. And there is a medicine which has come up. I forgot the name. It's a monoclonal antibody which has come up, which can help, but everything is sort of not at the stage where we can give parents a hope, conclusive hope.
All right, thanks, Dr. Vivek. Next case, over to you again.
So this is again a demonstration. This is again just the genetic disorder the child had, if that fits with the MRI findings. So five-year-old female child who was normal at birth, even though had fetal bradycardia, and since early age had global delay and central hypotonia. 4-month age had convulsive seizures, which were migratory in nature, but they responded to treatment. And then she was seizure free for 2.5 years. But when I saw her again in the last 1 year, she's globally delayed, autistic, thin build, central hypotonia, mild dyskinesia, no dysmorphism, well-controlled epilepsy. Do we have the videos by any chance?
Yeah.
So this is the video of her seizures at 4-month age. So bilateral clonus, uprolled eyes, maybe looking to the left side, and there were events which were separate to these where she just had right side or left side, and in the end there was right side clonus at the end in this video. So migratory seizures. And this is the second video on the right, where she has eye contact, but she does have autistic signs, hypotonic, non-ambulant, stands with help, non-verbal, but no seizures now. So significant delay. So that's her, right? So MRI changes, even though we see the central tegmental hyperintensity, but I thought this was more than just that. And it was done at 1 year age.
All right, exactly 1 year. Yeah, as you mentioned, bilateral central tegmental hyperintensity is demonstrating restricted diffusion over there. Possibly some reduction in the periventricular volume, which correlates with the thinning of the corpus callosum. So some white matter loss or reduction along the periventricular regions, slightly prominent lateral ventricles, at least the atria are slightly prominent over there. So yeah, central tegmental tract hyperintensity is the thinning of the corpus callosum and some reduction in the white matter volume. I don't have a T1 or other sequences. So yeah, this is what I had on the imaging. Again, once you mentioned central tegmental tract hyperintensity, we have already gone through this previously with Dr. Mankad. Say very non-specific finding, but can be seen physiologically up to around 15 months of age, commonly associated with epilepsy, especially West syndrome, and also if the child is on vigabatrin medication. So based on these findings, I think it's slightly non-specific given the age, but yeah, epilepsy was the feature of the child. It was present in the child, so it can be attributed to that. And then I think genetics was done up to it.
Yeah, that showed ATP1A1. Parents did not have this, so it was reported likely pathogenic. Magnesium levels were normal. So it's not the A2 or A3, so it's the A1. So this one I think you had shown.
Yeah.
You're showing
So
is the A2 and A3. So these
Yeah.
are the hemiplegic migraine gene and the alternating hemiplegia of infancy.
Yeah.
But this one is A1. So I just wondered if this is also another differential, if that central tegmental tract hyperintensity is important. Like, should we consider this clinical profile with CTI hyperintensity diffusion restricted as ATP1A1 also?
I've checked the literature, Dr. Vivek. I couldn't find anything specific on the MRI for this gene, very limited case reports. But yeah, might be a finding.
Right.
If anyone has similar experience with the gene or can correlate both the clinical and the MRI. Dr. Pankaj, sorry, I didn't get you.
No, I just said there's nothing to add right now.
Okay, all right. All right, this is the last of our new cases. I have 3 follow-ups. We'll go through them quickly. I don't think Dr. Srikanth is there, but I'll report this scan. So this was a 3-month-old child. I think it was a male child with unprovoked right focal seizures. Had some respiratory issues, had respiratory failure after the MRI. Also some the child also had vomitings. Was born to 3rd-degree consanguinity. And then the MRI was done at around 3 months of age. These are the diffusion-weighted sequences, and you can appreciate there is extensive confluent abnormalities of restricted diffusion in the white matter structures over there, bilateral hemispheres, peritoneic regions going up to the central submucoid, the internal capsules, external capsules, the pyramidal tracts, demonstrating predominant changes of restricted diffusion. There were some focal cortical abnormalities on the left temporal lobe, and also some bilateral symmetrical changes in the middle several peduncles in the infratemporal aspect. The brainstem tracts also demonstrated restricted diffusion. A focal area of left portothalamic hemorrhage was there on the GRE sequences. T2-weighted sequences again had the changes, edematous changes, along with some degree of hyperintensities along the anterolateral thalami, which is not seen on the diffusion changes. The pons again has additional white matter hyperintensities. And the spinal cord, we only did limited cervical cord screening, and that also demonstrated changes along the predominantly on the central aspect. Spectroscopy was done in the normal and abnormal appearing brain, and this demonstrated slightly, I mean, you can see that the inverted lactate peak over there. That was the main finding, at least what we thought on the spectroscopy. And then we thought that these findings could correlate with a modern metabolism or genetic disorder, mitochondrial disorders, going up to the organic acidurias, ITP, and encephalopathy. The entire spectrum was considered. And then the child was sent for genetics. And on genetics, it came out with the gene, NAXE gene, which was the first time, at least we have seen this gene. It was of uncertain significance. And then we looked at the MRI findings, any published literature. It is the mitochondrial gene which is responsible for the NADH metabolism. And the published literature demonstrated some similarities which are seen in our case, especially along the cerebellar white matter, the midcerebral peduncles, cervical cord involvement. Again, additional case reports again have these changes in the bilateral middle cerebral peduncles. It's part of the mitochondrial respiratory chain disorders, which is related to the toxic related changes. And again, there was a case series which demonstrated especially the clinical aspects had respiratory failure, delayed development, hypotonia, seizures. So your gene was of VS. Whether this gene is pathogenic or not is the question. So and then I'll open the case now. If anyone has similar experiences or further comments. Just to add
Actually,
the medicine.
yeah.
Sorry. Dr.
Yeah,
Yeah.
please.
Yeah.
Good.
Yeah.
So
Just to
there,
add the medicine.
yeah, Ramesh
Dr.
had a
Lokesh, go
similar
ahead.
case. Ramesh
Yeah.
had a similar case. Was stuck on ventilator after adding niacin, high dosages, supradine tablet. It's available. So the child gradually we could extubate her after almost 3-4 months, and made a good improvement. So this family was about to withdraw the after the reports of the this one. If it was a non-treatable condition, plan was to withdraw the care. But next day, we have seen that they can respond to high dosage of niacin. So we have started it. We'll have to see how long they would like to continue.
I think
Hello?
yeah, see,
Yeah.
yeah, Dr. Lokesh,
Yeah. Yeah, that's all I think. Yeah.
So at least imaging wise, there are some similarities with the lactates, with the structure of, with these changes in the cerebellum. It looks like a mitochondrial disorder, but we weren't so sure of this gene. So that was the only question. I can see Dr. Vijay and Caesar are there, especially Caesar if he has any. I'll share this case with Caesar and he possibly, Caesar, if you want to add anything to it.
Okay, there is a deletion, so that must be important. Frame shift, truncating protein, so and homozygous as well. Is that right? So that becomes very important.
Yeah, we have started acting on it. We are treating it. We're continuing the treatment instead of withdrawing the care.
Right.
I think Dr. Lokesh, Dr. Ramesh's case was an SCAR2 mutation, which had similar MRI changes, or was it the same pathway? I can't recollect the case.
Yeah, I would say that would be concerning about succinate deficiency here. I mean, not just because of the peak, but the white matter chains extending to the internal, the limbs of the internal capsule, and also the involvement of the pons. Basically, the base of the pons and the mid-subarachnoid peduncles are quite commonly seen in succinate deficiency, along with the spinal cord involvement. As Vijay was pointing out, and I think I had this impression that it seems to be a small peak in 2.4, which could be like pyruvate or even succinate, both within succinate in the same location. So I would be including this in the differential.
Max has nothing to do with succinate dehydrogenase. Yeah, Dr. Vijay, yeah, check that. I think it's a different pathway. Or Caesar, do you have any? Would you want to take that up? As far as I know, it doesn't come under the succinate pathway. The gene, the NAX gene. Yeah.
No, different pathway. But I'm not sure if this can come with another pyruvate peak or the similarities of the MRIs. I'm not sure because I don't have any case of this variant in my cohort.
So I think we'll get the parental testing done. Dr. Lokesh, is that the plan? I know this is Dr. Srikanth's case. Maybe I'll check with him. So yeah, we'll get the parental testing done and come back to the parental genes. All right, I have 3 follow-up cases with a suggestive or possible diagnosis. Devangna, if you're there, this was the case we have presented on 21st of July. Or if Dr. Lokesh can quickly summarize. This is the one with bilateral basic ganglion.
Yeah, there's a child. Yeah.
Yeah, go ahead, Dr. Lokesh. All right, so this was a child with, this is an 11-month-old child. Normally was previously they had normal development, presented with a history of fever, vomiting, diarrhea, and was normal in between for 72 hours with left focal status epilepticus and dystonic posturing. A series of investigation was done. In the lumbar puncture had 5 cell proteins were around 30, glucose was 40, lactates were slightly elevated 14.7. CSF panel was negative, autoimmune panel was negative. The whole genome, I think whole mitochondrial genome was done, which was negative. This was the MRI done. Initially, we had 2 scans on June 2023. We had these bilateral confluent abnormalities in the basic ganglia, some foci over there along the trigones. We could not appreciate any Sylvian fissure, widening of the Sylvian fissure, possibly slightly over there, but not very significant. And the T28 sequences, at least inferiorly down, the left Sylvian fissure was slightly widened in comparison to the right, but they were bilateral basic ganglia abnormalities, which also seen on the T28 sequences. Follow-up scan, you had some degree of clerosis, reduced volume of the bilateral basic ganglia. Yeah, so these were the main findings, some degree of cerebral atrophy, interval changes. Spectroscopy did not demonstrate any significant peaks, possibly a small lactate peak was there, but other than that, if we are calling that as a succinate peak in the previous scan, then possibly we should call this also a succinate peak or a pyruvate peak. I stand to be corrected by Dr. Vijay or Caesar. Devangna, if you want to quickly go ahead with the labs. Or a autoimmune panel was completely negative. CSF PCR was completely negative except for a positive mumps IgG and a Klebsiella pneumonia. TMS was done, which was negative. This is the whole genomic, I think, sequences, which did not demonstrate any variance. Then we thought of the possibilities with glutaric acidurias and other organic acidurias with mitochondrial disorders as a differential. And this is again a whole exome was done. If Dr. Lokesh wants to just elaborate on the finding.
Yeah, I had a compound heterozygous mutation in the glutaric aciduria gene. Although the TMS and urine organic acids done in a particular lab didn't pick up anything, we have asked them to repeat in a different lab, which they are doing it. And after the last discussion, we had started on the diet, J1 diet. The child is slowly improving. And this has confirmed we are repeating, we are doing the parental testing segregation.
Yeah, I think Dr. Mankad also agrees, Namandeep also agrees. So yeah, thanks. Kirti, if you're there.
Yes, we had discussed this case. This was a 3-year girl had a baseline developmental delay and had presented with a severe metabolic crisis triggered by viral illness. And she had hypoglycemia, severe metabolic acidosis, hyperuricemia, high ketones, lactate ammonia were normal. And she was managed with this one, dextrose infusion and bicarbonate infusion. And we had the MRI, which was showing bilateral basal globus pallidus diffusion restriction. And we had the metabolic TMS and GCMS, which were not corroborating to each other. Like we had branch and amino acids elevation in TMS, but it was not corroborating with GCMS. However, there was some 2-methyl butyric acid elevation in urine, which could suggest beta-ketothiolase deficiency. But again, the corroborative metabolite was not there in TMS. So we didn't have a particular answer, but we had started this child on low protein diet, suspecting it to be MSUD because of the high elevated branch and amino acids in TMS, and had sent the genetics. And the genetics actually showed a CAT1 mutation, which is actually beta-ketothiolase deficiency. And then we reviewed back, and we had the suspicion of beta-ketothiolase as well. So that confirms the diagnosis. And it's pathogenic. Yeah, of course, it was a heterozygous mutation for an autosomal recessive. It was a single variant identified, but because of match with the GCMS and the neuroimaging findings, we thought that this could be responsible, a CAT1 mutation.
Yeah, thanks, Kirti. Anyone has similar cases?
It's just surprising that with heterozygous, they gave pathogenic just by clinical match. Is that possible?
The variant that they have found for that particular single variant, they have reported it to be pathogenic.
It's autosomal recessive, so
Yes.
it has to be compound heterozygous or homozygous. That's just.
So the whole exome couldn't.
Normally, they would have given VUS rather than pathogenic.
Yeah.
I think we need to look for other hit. Either you need to discuss with the lab to see if is there another way to look at other hit if it is a larger deletion, which is not picked up on this. Yeah.
because this will not confirm the diagnosis.
Okay. Okay.
Yeah, sure.
Yeah. All right. Thanks, Kirti. Thanks for the work. And we have a last case, Rapsayani, if you're there.
Yes. So we had a 7.5 years old boy who was already diagnosed case of thalassemia major with ongoing regular blood transfusions. So the child had a baseline intellectual disability, but at 7.5 years of age, he presented to us with continuous high-grade fever and basically progressive Parkinsonian features. And he also had a history of symptosis 1 year back, but that was attributed mostly to desferoxamine, and the child was in remission. Investigations didn't reveal any infective focus. The CSF was normal. However, the blood gas showed that there was compensated metabolic high anion gap metabolic acidosis with elevated lactate. Otherwise, ketones, ammonia, glucose were normal, and TMS GCMA screening was also normal. So the MRI showed.
You want to quickly show the video?
Yeah, if time is. So
Yeah,
he
yeah,
had
yes, yeah.
basically progressive. He had cogwheel kind of rigidity, tremors, and he was all throughout bradykinesia, hypokinesia, everything. Short suffering gait was also there gradually, and he would also have a intention component of the tremors.
All right. The MRI comparison case to a previous scan. Again, bilateral symmetrical edematous changes in the corpus tragus, additional abnormalities in the midbrain over there, and the subthalamic nuclei, the hypothalamus, some degree in the also in the mammillary bodies, optic tracts, but predominant changes were in the deep brain nuclei and the brainstem, the midbrain. They also showed restricted diffusion. Yeah. So yeah, these were the MRI changes. No contrast enhancement or no significant enhancement on both contrasted. Again, differentials were discussed. We thought of mitochondrial as I think the first possibility, if I'm not mistaken.
Yes.
Yeah.
So the genetics were sent. So apart from a compound heterozygous variant in the thalassemia, that is the hemoglobin B gene, so there was a likely pathogenic variant in the 3' splice site of the PDH E1 alpha subunit.
So the imaging at least matches. I think clinically also it matches, if I'm not mistaken.
Yeah, clinically
Yeah.
also the child fits into the diagnosis.
I think the question was raised about the treatment we have discussed, I think, yesterday regarding the.
Yeah, actually the child, this I also discussed with Lokesh sir. So actually the child was about to be going for the transplant last month. Before that, he presented to us with the neurological. But then we discussed, we saw that the long term, although the child at 7 years, like he was only symptomatic with some form of intellectual impairment, but now he's having a very fluctuating course with intercurrent illnesses. He's regressing, and then again. So we have discussed with the family. So the family is yet to decide. But they are mostly willing to go for the transplant, although the neurological prognosis has been explained to them.
Sridhar, do you want to add anything? Any new treatments going out there?
Yeah, I think we had wonderful 5 cases with basal ganglia lesions. 4 we have a different genetic diagnosis. Each one of them confirming this kind of wonderful session. Thank you.
Thank you. And that is our last case. I'm not sure if we'll meet again on 15th because it coincides with the spin course. Dr. Mankad, do you want to?
Yeah, just a little point about the last case. Is Vivek still? Because I thought Vivek was publishing the PD, or he was a part of the last paper that was published. Would he be happy calling it consistent with a likely pathogenic mutation?
Yeah, I haven't published anything, and I don't have. I think you must have.
Because I remember sometime back.
I remember, he had the PD one with Korea dystonia.
Yeah, yeah. It obviously is consistent, but as I remember, I mentioned that I had a case similarly who had drug-induced, deferipon-induced. So I don't think this is something, such a learning, it's a good learning, and I didn't think of this.
Perfect, thank you.
And
about spin. So guys, if you're listening and still, the whole idea is to have a structured training program for radiologists as well as clinicians who want to learn everything about neuroimaging in children with some adult correlations. So if you are interested, please do join this. And the virtual part 1 and part 2 is going to be at your own pace. Of course, we're doing the step 3 in India later on next year. So it'll be great to have you on board. Please spread the message to your colleagues if they might be interested as well. The whole idea is to standardize practice, improve and upscale what people are doing for children.
So will it be India time? Is it India
Yes, the
time?
times are all India time at the moment.
Yeah,
Because
and
it
just
kind of falls well for the East and West as well, the Indian
Right.
times.
Just for the speakers, because I did attend the orbital imaging, so it was so top of our, for a pediatric neurologist, if they can sort of tell us the basics, about orbital. I think the topics are orbital imaging, vascular imaging, spine imaging, and these are our weak parts. For us, brain is okay, but the vascular, orbit, and the spine, at least for me, is so weak. So if they can sort of talk about the basics and how to look at it and then go into.
Yeah, I get it, Vivek. And in fact, it would be great for you all to even come and debate on things that you might want to add value to, because everything that is spoken may not be, I don't even trust any religious books anymore. I think we should question every norm, but we learn when we question. So please be there if you can. And
Yeah, I've registered. I've registered already. Looking forward to it.
Yeah.
Thank you.
And thank
All
you,
right.
Nihaal.
Thank you, Dr. Pankaj. Thank you, Dr. Vivek. And thanks everyone for your active participation. We'll try to reschedule our meeting because it clashes with the step 1 course. I'll get back to you. We'll put it on social media for next meeting. Till then, see you soon, and hopefully most of you will join us on the step 1 spin course in 2 weeks' time.